We are live, ma'am.
Okay, Vasant sir, shall we go ahead?
Sure. Continue.
Yeah, thank you, sir. A very warm welcome. Good afternoon to all of you for our 7th episode of Academics with Institution. We are back with a very prestigious institute, Niloufer Hospital from Hyderabad. So at the outset, I would like to welcome our respected President, Dr. Vasant Kalatkar sir, our President-elect, Dr. Neela Mohan ma'am, immediate past President, Dr. Basavaraj sir, our Yogesh Parekh sir, Honorary Secretary General will be joining in soon. And welcome our Treasurer, Dr. Atanu sir, and welcome all our dignitaries present over here, our past President, Dr. Pramod Jog sir, our great teacher, Dr. Srinivasan sir, our advisor, Dr. Jagdish Chinappa sir, and first and foremost, our participants today, our chairperson, dear Vijay Kumar sir, thank you so much for coordinating and bringing in Niloufer Hospital. We tried a lot last year. It was cancelled almost 3 times. So I am more happier this year that we could able to bring in Niloufer Hospital in academics with institution. Welcome all the faculties, Dr. Tilak sir, Dr. Suchitra, Dr. Prashant, and all others from Niloufer Hospital. And I would now request Dr. Atanu sir, in absence of our HSD, Dr. Yogesh Parekh sir, to deliver the welcome address. Over to you, sir.
Thank you, Dr. Priya. So now again on this Friday, we are there in Niloufer Hospital. It's of course academic tourism and a program that has been going on for almost 1.5 years now. Thanks to both all the presidents, the inspiration of Dr. Vasant Kaletkar, Dr. Basav sir, and Dr. Neelam Mohan. So I think hopefully this was one of the most important program, one of a kind. And Dr. Priya, Dr. Jagdish Chinappa sir had been behind the backbone of this academic program. And today we are in one of the best institutes in the country. Just a few days ago, I was having tea with Dr. Vijay sir in the medical superintendent room, and Suchitra, and they were all there. And even I met Dr. Suresh, who was connected to it. In fact, IIP, many stalwarts from IIP are connected to Niloufer Hospital. So today we are, thank you for organizing this thing, organizing the academic institution, and we are looking forward to a really inspiring program. So I think, Dr. Priya, I think you can conduct the program now. Yeah.
Thank you. Thank you so much, sir. I welcome our Central Zone Vice President, Dr. Guru Prasad, sir, and East Zone VP, Dr. Prashant Sabot, sir. Thank you so much for joining in. Basavaraj, sir, welcome, sir. I would now request our National President, respected Dr. Vasant Kalatkar, sir, for your opening remarks. Sir, please unmute, sir.
Unmute, sir. Dr. Vasant, sir. Oh, yeah.
Okay. Am I audible?
Yes, sir. Yes, sir.
Yeah. So, respected all dignitaries today's Academic With Institute, respected Dr. Neelam Mohan, who is the President-elect, Dr. Yogesh Parekh in his absentia, our charming and ever-helping past President, Dr. Basavaraja. I think he should be continue presidentship. Our past president today, Dr. Pramod Jog, who is always behind us and always for academic. Dr. Atanu Budra, our national treasurer. Then Dr. Srinivasan, especially I will mention this from their connectors. He's still joining, and at 5 AM he is there. All Dr. Prashant, Dr. Prasad, all my vice president, all EB, OB member, the person who are involved for this academic with institute, all the those who are working hard, Dr. Priya, Dr. Jenappa, and Dr. Tilak, team of Hyderabad Niloufer Hospital, and all my near dear IPS. It's really, I welcome you all from Indian Academy of Pediatrics. It's an honor to be part of episode 7 of Academic Institute 2, a flagship initiative of Indian Academy of Pediatrics, that is the redefining how we share, celebrate, and scale academic excellence in pediatrics across India. Really, it's a great thing. After completing 12 episodes last year, still we are live and 7 episodes we have covered. I always feel that my year is lasting at it's only 5 months and what to do. But really, hats off to Dr. Priya, especially, and all this team. They are really working hard for this academic institute to be complete, continued, and it should be live. Today's session, hosted by Department of Pediatric, Niloufer Hospital, Hyderabad, reflect exactly what this series stands for, bringing to light models of care, mentorship, and medical education that are equality, realism, pediatric practice. A heartful appreciation to my colleagues and leaders who have made this episode possible. I also commend the host institute esteemed team with Dr. C. Suresh Kumar, Dr. Vijay Kumar, Dr. Tilak, Dr. Suchita, Dr. Srikant, and our bright PG student Dr. Priyadarshini, Dr. Mallikarjun for sharing their valuable insights and stories today. Niloufer Hospital need no introduction. Whenever we go to Hyderabad, it's the one spot. Niloufer for academic and Baharwali chai with bread. It's always. There are so many new dignitaries from this hospital who have we got for IP that they are the really diamond for us. Really, thank you, Niloufer Hospital management, for bringing up such a diamonds from your institute. It remains one of the country's iconic center for matter and child health, where generations have been trained and treated with equal care. But today, we focus not just on its past, but on how its current practices and academic model can inspire institutions across India. This program is not merely a presentation, it's a blueprint for collaboration, mentorship, and academic consistency. It offers young pediatricians a lens into how institutions build ecosystem that nurture clinical excellence and research relevance. As president of IIP, I see this platform growing into a moment, one that not only honor academic legacy but achieve documents and disseminate institutional wisdom for next generation. Let this episode ignite ideas. Let it inspire departments across the country to open their doors, share their journey, and build the next wave of pediatric leaders. Thank you all once again for your presence and participation. Jai Hind, Jai IIP. Thank you.
Thank you. Thank you so much, sir. I would like to welcome our respected chief guest, Dr. C. Suresh Kumar, sir. Thank you so much for joining in for today's program. I would request our president-elect, Dr. Neela Mohan ma'am, who has very fond memories of Niloufer Hospital, to share her thoughts.
Thank you so much, Priya, respected Vasant Kalakar, Baswaraja, past president, and Dr. Pramod Jo, who always joins this program as one of the past presidents in that, Yogesh Parekh, Atanu, Guru Prasad as the vice president of that zone. And I can see Prashant, then probably if I'm not able to see the other two, Ramesh and Preeti, if available. With that, I also wanted to say our respected yes, Vijay Kumar, whom we met each other several times because being from Hyderabad, I have a very strong connection. And all the dynamic people who are still working there, not only Dr. Suresh Garu and Dr. Tilak Garu, but Lakshman, Galapati, Suchitra, and Srikant. I've seen their dynamism when I've been in the installation and in their local, the energy that is vibrating there. And the young girls, Priya and Malik, I'm looking forward how you're going to rock because you're going to remind me of what I did. I just wanted to let you all know it's not, Niloufer, the moment think about it, it's an institute you're going to hear more, but I'll just tell you that why is it called Niloufer? There was this Princess Niloufer who was married to one of the Nizams in Hyderabad, and her maid died due to childbirth. And in 1950s, she felt very upset and decided to come with a hospital which was for the community for mother and child, and it started as 100 bedded, and today you see it's a 1200 bedded with maternal care children. And we as residents, not only from Usmania Medical College, we would be posted there for either the gynae or obstetrics or the pediatric or neonatal care, but also from the Usmania Hospital, we would be posted for pediatric care. So it's one place where you would see everything. If I say 1200, even my time, late 1980s and early 90s, that 90 that I did my, the amount of cases that we would see was which you would never miss what you would have seen in the book. So it's so much that they have taught us, and I'm so very grateful. It is the love and passion of that institute hospital that today I'm a pediatrician. I used to be the blue-eyed girl of Dr. Ajit and Dr. Vaisi Mathur and Ajit and them. So with those fond memories, I would say I'm sure there's much more to that department than what I knew then, but still it rocks memories of love and happiness when I think of the institute.
Thank you. Thank you so much, ma'am. I request our immediate past president, Dr. G.V. Basavaraj sir, who has visited Niloufer Hospital, I think, multiple times, to share his thoughts. Over to you, sir.
Yeah, thank you. Thank you very much, Dr. Priya. And respected our National President of Indian Academy of Pediatrics, Dr. Vasant Kalatkar ji, our President-elect Neelam Mohan ji, Honorary Secretary General Professor Yogesh Parikh, Dr. Atanu Bhadra, and Prashant Sabot, and all other seniors who has been joined, and of course, our past President Pramod Joshi and all. So this is a really Niloufer Hospital is a mecca of pediatrics where I visited. The looking at a public sector hospital which is doing a great work. All the credit goes to the stalwarts and present medical superintendent Dr. Vijay Kumar ji and Trilok Chandra sir, Dr. Suchitra, Dr. Shrikant, and all the seniors who has been putting a lot of efforts there. And in fact, to the Indian Academy of Pediatrics, Niloufer Hospital is always contributed in a constructive way. Lot of things, whether it is a research, whether it is an academics, or it could be in a conducting organizational skills. These are the things which are the really rich contribution from the Niloufer Hospital. And Dr. Vijay Kumar, sir, per se, I am closely associated with almost for 2 decades. One of the training up in a practical pediatrics, myself, Dr. Vijay Kumar sir, Dr. Srinivasan sir was also sir is also here. We have been formulated that module where Dr. Vijay Kumar sir was fantastically created a module on nutrition that has been in a benchmark, and it has in fact so it has changed in a whole what we are talking about today, small nutrition. That's how the commitment of Dr. Vijay Kumar sir, not only to the nutrition and also to the immunization also. Coming back to our academics through the institution, which has been greatly conducted by Dr. Priya Shivalli, our national coordinator, under the guidance of our chief advisor of this program, Dr. Jagdish Chinnappa. I'm sure it will create a lot of enthusiasm. Our Central Zone Vice President, Dr. Guru Prasad sir, who has been very, very instrumental in coordinating with all the EB members to take the academics to the nook and corner of the country. Thank you, Dr. Guru Prasad sir, Ramesh Bajania ji, Dr. Preeti Galigali, Dr. Prashant, and all the vice president who has been richly contributing to it. Best wishes for the today's program.
Thank you. Thank you so much, sir. I would now request our Vice President, Dr. Guru Prasad, sir, to introduce our respected chief guest, Dr. C. Suresh Kumar, sir. Over to you, sir. Sir, please unmute, sir.
Okay. Thank you, Priya ma'am, for giving me this opportunity to address this August gathering of IAP, Central IAP, all stalwarts who are doing very great work in IAP. and at the same time I thank Dr. Vijay Kumar sir and all team of Niloufer for accepting this invitation to join in our meeting in a short notice and preparing for this program. And my respects to all our seniors, including our president sir, Dr. Vasant, our Neelam ma'am, as Prashant wrote just now, Neelam and Niloufer, what a great coincidence. Both growing fast. Privileged to listen to Dr. Neelam. Niloufer Hospital is a dream institute for many in all parts of country. Ma'am, Neelam ma'am, you have very good compliments from our Prashant. So extend your thanks to him, ma'am. Right? So, now coming to the guest speaker, that is Dr. C. Suresh Kumar sir, who was retired HOD Niloufer and also superintendent of the Niloufer Hospital. He had got many credentials which doesn't need any introduction. And I request Dr. Suresh Kumar sir to take over the mic. Thank you, sir. Thank you, madam.
Thank you, Doctor. Thank you, Dr. Guru Prasad, for a nice introduction.
Sir.
And at the outset,
Yes, sir. Right.
I'd like to thank the Central IAP as well as the Executive Board as well as the coordinator, Dr. Priya, for conducting this program, which I like very much because it
Please
is.
stop sharing slides now.
Yeah.
Yeah.
Hello.
So please go ahead, sir.
Yeah. It is like remembering your mother, alma mater to the students. So, as somebody has already said, Dr. Basaraja, it is a mecca of pediatrics. You name any case, if you are not seen, if you have seen, say, 5 cases in Nelson, you might have seen in Niloufer at least 3 out of that. So such rare cases also we can see. So coming to the today's presentation, as already been said, it is named after the Princess Niloufer, who is the daughter-in-law of Nizam, and she was the one who donated the money to construct the hospital. So Princess Niloufer was the second daughter-in-law of erstwhile King of Hyderabad, Nawab Mir Osman Ali Khan. So initially it started as a 100-bedded hospital with 50 pediatric and 50 gynae beds. And it was a VIP hospital because all the deliveries of high-profile people used to take place there. Then the inauguration was done in 1953. It was opened by Union Health Minister Rajkumar Amrutkar at that time. Then it was later designated as Institute of Child Health and inaugurated by Vice President Dr. Sarvepalli Radhakrishnan in 1957. Then it was expanded from under the leadership of Dr. Harishchandra, who was the first superintendent of the hospital. In 1958, it was extended to 150 beds. Then in 1963, OP was constructed, then which was demolished later, and now we have an intensive care block there. So this is the intensive care block. It was demolished, and the OP was demolished and constructed. And we have now new OP building, which is a 5-floor NATCO OPD block, which also houses a state-of auditorium on the 5th floor and a IAP office as well as NNF office there. So this was one of the biggest in the Southeast Asia to have an intensive care block of 450 beds. So it has got the NICU, PICU, we have got the blood bank, milk bank, everything is there under one roof. The intensive care block it was established in 2012, inaugurated on 14/11/2016. Our comprehensive departments include, apart from the pediatric surgery, ophthalmology, neonatology, pathology and microbiology, obstetrics, neurology, and cardiology, as well as pulmonology. Then we have comprehensive care and modernization, which are depicted in the Niloufer Hospital. Now it has been extended to current bed strength is 1230. Even though the bed strength is 1230, any day you have anywhere from 2 to 2,500 patients. It also has got advanced facilities like pediatric ventilator, multi-channel monitors, infusion pumps, temperature regulation equipment. So you name anything, everything is there in there. And OPD services, we have about 1,400 children attended daily. That is there in the NATCO block, as I already told you. I want to tell about the dozen specialties of Niloufer Hospital. First one is, it is the first institute of child health in the country, opened on 5th November 1957. First neonatal unit with professor of neonatology in the country was established in Niloufer Hospital. First pediatric surgery super specialty unit recognized by MCI for MCH pediatric surgery course in the country was established in 1977. First in the country to have neonatal surgical unit. First unit for emergency pediatric service in the country was first established in Niloufer Hospital. One of the first school health departments was created in Niloufer Hospital. Nutrition was started in collaboration with NIN and was converted to Nutrition Rehabilitation Center with 20 beds with aim to reduce and manage malnutrition. All of us are familiar with Hyderabad mix, which we used to give in earlier days. It was done and designed in Niloufer Hospital by NIN. Then we have the state-of-art excellence for HIV, AIDS, and Pediatric Regional Center for ART. We have got pediatric neurology, pediatric cardiology, and pediatric psychiatry units established 4 decades back. We have eSNU, where 44 SNUs are connected to the telemedicine center, where virtual rounds are done, parents are counseled, and guidance is given to the medical officers. And it is the one of the units, 8th in the country, to get Laksha certification for maternal care quality. It is very difficult to get, and the Niloufer has got in 2023 November. Niloufer also has a Shishu Bihar unit, where we have 20 beds to take care of orphan children, milk bank, and DEIC center. So, what about Center of Excellence in Niloufer Hospital? That is eSNCU. So, it's a virtual rounds attended by eSNCU doctors. The team from here, they will be monitoring all the SNCUs and they'll do any difficult cases are there. The medical officer talk to them and then they discuss by doing virtual rounds. Then counseling the parents for the babies by ESNU doctors. This is a console from where they counsel. And there is a virtual meeting with all SNUs, that is ESNU doctors from Niloufer. You can see Dr. Swapna, who is a professor of neonatology, and her team. Every day in the morning, they do rounds, virtual NICU rounds, and then counsel the parents as well as guide the SNCU doctors. So coming to the Department of Pediatrics, it is the first institute of childhood in the country. It has got highest number of pediatric postgraduates, 60 MDs. Dr. Chandraya, professor and HOD Department of Pediatrics, is heading the unit now. We have 12 units with 40 beds per unit. Separate and dedicated PICU and RICU units are there, which are 150 bedded. And you have NICU, which is 150 bedded, but any day, 120 bedded, but any day there are more than 300 units. I think it will be the highest in the world, if I am not overestimating. So much is the turnover of Niloufer Hospital. You can see the students as well as the faculty photo here. So coming to the courses, DCH was started in 1958, MD Pediatrics in 1967, MCH Pediatric Surgery in 1977, and DM Neonatology was started in 2014. So this is another photo of the faculty as well as the PG students of Niloufer. Yeah. Coming to the Department of Neonatology, Dr. L. Swapna is heading the unit. Earlier, Dr. Alimelu was there. Before that, Dr. Himabindu was there. So now we have, when we started, way back in 2014, there's one DM neonatology unit seat was allotted. Now we have got 5 DMs in that. So here we have got affiliation with Usmania Hospital, NIMS, as well as MNJ Cancer Hospital to sort out high-risk cases and those who require liver transplantation, bone marrow transplantation, cardiac surgeries. We coordinate with these super specialty hospitals and get the treatment done. Of course, the operative workload, you can see so much. Major surgeries 15 to 20 every day, minor surgeries 5 to 9, and operation theaters you have got 4. Then pediatric surgery, obstetric, gynec, they have got lot of turnover. And then histopathology, cytopathology, hematology, biochemistry, microbiology. These are all laboratory workload and diagnostics. So advanced radiological service. Plain X-rays are performed in 2025 as of now. As of today, 30,629. Ultrasound scans 34,256. CT scans 2,941. We have MRI services which are being taken care from adjacent MNJ Cancer Hospital. We are going to get the MRI shortly. Then this is the leadership through the decades. Niloufer Hospital has been guided by distinct pediatrician, ensuring its continued excellence. Dr. Harishchandra, first superintendent, he was the president of IAP. He nurtured the hospital into a premier institute. He was the longest serving superintendent for about 17 years. Dr. Y.C. Mathur was the past president of IAP in 2001 as a faculty of this institute. Dr. A.S. Narayana got Padma Shri and B.C. Roy Award, was in charge of school health, Niloufer Hospital. So senior doctors of the state in the field of pediatrics have had the privilege of being appointed as superintendent of the Niloufer Hospital. They include Dr. Harishchandra, Dr. Lavanya Mukherjee, Dr. Y.R. Reddy, Dr. G. Purushottam Rao, Dr. S.V.R. Reddy, Dr. Mirabai, Dr. P.S. Murthy. Dr. Sheila Karan was the first neonatologist of the country, as well as the first unit established in the Niloufer Hospital. Dr. M.C. Mathur, Dr. M.M. Reddy was a renowned pediatric surgeon. And Dr. Sogra Begum was a cardiologist who had died for some time. Dr. N.C.K. Reddy was also the pediatric surgeon. Dr. Indra Shekhara, all of you must be aware, served as Vice President of Central IIP. Dr. A.B. Gnaneshwar, Dr. Narasimha Rao was one of the pioneer superintendents, where under his superintendentship, the new block was foundation stone was laid for the new Rajiv Intensive Care block. Then, of course, all of you are familiar with Dr. P. Sudarshan Reddy, who was the organizing chairman for 2010 Pedican. Then we have Dr. Vikramjit Singh Vasu, Dr. Ranganath Darur, all of you are aware, Dr. Subramanyam, Dr. Devaraj, Dr. Suresh Kumar, that is myself, and others. Of course, the present Professor Dr. Vijay Kumar is the superintendent. All of you are aware of his academic status. Then the present DME, Dr. Narendra Kumar, was faculty of this institute, and present additional DME, Dr. Shivram Prasad, was also faculty of this institute. As Dr. Neelam has told, she is also associated with Niloufer. Thank you, Dr. Neelam, for remembering Niloufer. And award about Niloufer and National Pedicons. First All India Pedicon was held at Niloufer Hospital on 1st April 1963. The Pedicon 1980 was done in Usmania Medical College by Dr. Harishchandra. And Pedicon 1990 was done by Dr. Sheila Karan as organizing secretary. Pedicon 2000 was organizing secretary was Dr. K.V. Raghavarao. Then Pedicon 2010, I think most of us can remember because it's a recent one. Dr. P. Sudarshan Reddy was the chairperson. Myself was the organizing secretary, scientific. Dr. S. Sanjay and Dr. P.V. Rao were the other organizing secretaries. Then APCP Pedicon, that is Asia Pacific Pedicon, was held not long ago, that is 2016. Dr. Jagdish Chandra was vice chairperson. Dr. N. Ravi Kumar and Dr. Ajay Kumar were the organizing secretaries. Of course, all of you must be remembering the recent Pedicon 2025. where Dr. Neeli Ramchandar, who was our student from Niloufer, was the chairperson, and Dr. Surendranath was the organizing secretary. And some of the eminent personalities who visited Niloufer include Waldo E. Nelson, who has written the great textbook of Nelson's textbook of pediatrics. Ellen Mary Avery, who is involved with this dexamethasone theory, and Dr. Dharmapuri Vidyasagar, who is a well-known neonatologist worldwide. He was instrumental in having Indo-US partnership for training the Indian students, Indian faculty and students there in America, and he used to get team of pediatricians and neonatologists from America. Dr. Phil Pott, Dr. Balu Atreya, all of us are familiar, is a clinical book he has written. Then, of course, the Pandit Jawaharlal Nehru, first Prime Minister of India, along with Dr. Maulana Abdul Kalam Azad, Dr. Neelam Sanjeev Reddy, they stayed in Niloufer Hospital during the visit to Hyderabad in 1953 for AICC session. That is in brief about Niloufer Hospital. Because of lack of time, I just restricted to the important points. Thank you for patient listening. Over to the organizers. Thank you.
Brilliant.
Thank you. Thank you. Thank you so much, sir, for the knowledge given about Niloufer Hospital in a very short time. I think you covered a lot of the things from the beginning till now. Thank you. Thank you so much, sir. And your presence means a lot to all of us.
Thank you.
I would now request our Central IPEB member, Dr. Lakshman Garlapati, sir, to introduce our respected chairperson, Dr. Vijay Kumar, sir. Over to you.
Thank you, Dr. Priya. Good afternoon, everyone. So, Dr. Vijay Kumar, sir, Dr. Vijay Kumar Gooder is the professor, senior pediatrician, head of the department, Niloufer Hospital. He's also the superintendent of the Niloufer Hospital and also Usmania Medical College. He's the president-elect PATS 2025. He had contributed 34 publications. He's the chairman, board of studies, Kaloji Health University, Telangana. And he is a coordinator for journal coordinator for PALS and member of ACBIP. And he's my classmate. We studied together at the post-graduation. I welcome you, Vijay Kumar, sir, for this 7th episode of Academics with Institution program. Yeah, over to Dr. Vijay Kumar, sir.
Welcome, Vijay Kumar, sir. It's really great thing you are presenting the cases, and that to be something different aspect. Yes. And hats off to Dr. Priya, Dr. Niloufer.
Yes, sir. Thank you. Thanks. Good afternoon, President sir, past President sirs, Srinivasan sir, all my teachers and all the dignitaries here. Now, after very special thanks to Dr. C. Suresh Kumar sir for explaining about the Niloufer Hospital, and it has been a God-given opportunity for me to be chairing this session. This is very you are seeing Dr. Chandraya sir, who is presently HOD now, and Tilak Chandrapal sir, who is my teacher. When I was in Niloufer Hospital, he taught me, and Dr. Suchitra professor and Dr. Srikanth Associate sir, they actually mentored the 2 cases here. And sir, one word from sir.
So I only cover the things which were missed. One is, of course, this institution is affiliated to the Kaloji Narayan Rao University of Health Sciences, which is stationed at Warangal. The headquarters is at Warangal. And Kaloji Narayan Rao is a very famous poet. He wrote many books and the poems, and is very famous in Telangana region. That is one aspect. Of course, the medical director and additional director for education, both of them are from Niloufer Hospital. That is a great pride for us. And working in the government hospital definitely has an advantage than other institutions for the students. They are exposed to not only various cases, but also to various professors at the same time, and they gain a lot of knowledge. And in addition, we have NIN, CCMB, Genetics Institute, CDFD, which are the government the institutions outside, and which collaborated with the Niloufer Hospital for many research. work, and also the directors of NIN, Dr. Vinodini Reddy, Dr. Bhaskaram, Dr. Hemalata, all of them, they taught us nutrition at Niloufer Hospital while they following the cases in the rehabilitation unit, nutrition rehabilitation unit. And I wanted to acknowledge these things. Thank you.
Sir. So am I audible, sir?
Yes, sir.
Yes, sir. Actually, regarding I'm going with my presentation, sir. Right. Actually, when I was asking Priya Madam and other my colleagues, seeing the social pediatrics role of Niloufer Hospital and the collaboration they had with NIN, and one of my classmates is retired as deputy director, very recently was the Dr. Lakshmaya. I thought I would talk about SAM management. But then this was my topic because there are from 100 students to 250 undergraduates, 60 postgraduates, and another 56 gynops PGs, pediatric surgery, and DM. I thought the utilization of skills lab, though there may be not medical teachers, there are also general pediatricians and non-teachers in this group, but every doctor is a teacher. That way, regarding skills lab, I thought I would share my views in a very large hospital. Now the buzzword is skill and competence. India today offers education conclave. So the buzzword is skill and competence. In the medical education, it is much more important nowadays. Life skills, which are very, very important, and we learn lifelong. And the Indian medical graduate, there are of the 5 roles, they said a lifelong learner. I thought what we were taught by the great teachers and what is that is followed as so-called CBME, the competency-based medical education, which we follow. I somehow realized as a teacher that there are many, many points of that CBME that are explicitly taught now, are already there as an hidden curriculum in taught by the great teachers you have heard right now. C. Suresh sir, Tilak sir are by my side. And then professional skills, and I request you to see the I, E, and O. I'll explain a bit on this. Certifiable skills, this is called. And when the students that we teach who gain competencies, who master their competencies, the patient outcomes are good. And not only the patient outcomes, it is not the discharge of the patient, the quality of the patient, and how our younger generation students, they present to the community and to the patient, which are explicitly taught as EdCom skills. The learning is a transformative learning. That is a core of the CBME. The instrumental learning and communicative learning are 2 parts of it. Instrumental learning is not AI. It is learning through a task-oriented problem solving and to determine cause-effect relationship throughout the life. Instrumental is these 3 are the aspects: task oriented, problem solving, and cause effect relationship. One issue is one great point in the CBM is that cognitive domain, while it remains a core point, these cause effect relation, task orientation is stressed more. Communicative learning is again the patient's feelings, desires, and all this. See here, this is called instrumental, and they're not learning through this thing. Actually, a case scenario is being given, which the students are seeing there, and then after that, the case would be discussed. Depending on the discussion, it goes to any extent. This is called instrument learning. This is supposed to be more than giving a theory classes and cognitive learning. What is this? Is this a hospital or anything? The lady that you are seeing is a medical officer who is a pediatrician. She's NRC medical officer. We knew many words about when we were students. We heard about marasmus, Koshiarkar, great research done, and then suddenly there was only one nutrition ward by the side of the first unit in Niloufer Hospital, and then the treatments were quite not reachable. And this lady, when she is into medical officer, she went to the NRC and she is along with the nurse and nutritionist, she is cooking the food. This is called a lifelong learning and experiential learning. The experiential learning, when there were no answers in your undergraduate time, somewhere in your professional life, you have got answer to it. The treatment of Sam is not in a pediatric ICU, it is in the kitchen. And objective of my talk are what are the skills, what should be taught, and in which environment they should be taught. The facilitatory skills the medical teacher should know. And one more word I wanted to say is skills lab. Different medical colleges, there are thousands of colleges now in our country. Skills lab is not a room where there are many mannequins, and the costlier the mannequins, high fidelity mannequins, it is the best skills lab. It is not so. The purpose of skills lab is very, very different. It depends on a lesson plan, like all our traditional teachers have taught us. The skills lab is one appendage of a lesson plan of a teacher. And what is a skill? Any action by a healthcare professional involved in the patient care for a measurable clinical outcome. The skills are many: procedural, clinical, you are seeing there. In other words, the cognitive, clinical reasoning, decision making, all these are given a lot of importance, and manual dexterity, other things. Leadership skills would come. I'll just show you in my fragment things. So the Indian medical graduate that we teach, when we treat patients for a better outcomes, it is the expert team which is very, very important, not the team of experts. There are many hospitals, not to criticize any person. There's a cardiologist who come and gives his notes, nephrologist gives his notes, one round per day, and it is not this thing. And a group of expert team with a desired patient outcome is that we want to teach our students. See here, one girl, this girl is managing a rice mill, others are quite tense. The postgraduates have intubated, and these babies are going to go for the ventilator. And a senior nurse has come, see the relief in these girls. And whenever we teach skills lab is an optimal place. Teaching skills is, there are two important factors: feasibility and criticality. You know that ambu bag or the self-inflating bag skill, it is very, very feasible, and it is also a critical skill. So we teach it not only to postgraduates. Actually, postgraduates are interested in intubation and ventilation, not really bagging. So this is one skill. This we go down and we teach to even nurses and any person. CPR the same way. The skill which is both feasible and critical, we want to teach to everyone. See now, this is another skill, defibrillation in PICUs. Even the busy PICUs, they use it once in 2 weeks or so. See the tension there. See the other boy who is yet, it's a mannequin as such, but in a real life situation, this is the importance of a skill lab. The other person who is going to learn is a skill, you see him. This is another skill which is made very famous everywhere, a very, very life-saving skill. Both criticality is there, feasibility is there. And even the NELS team, Dr. Suchitra has made this intraosseous route in adults also. She has that drilling machine. It is actually like a carpenter's drill, and even in adults she has made it famous. A critical skill and a feasible skill. And I said this I, D, and O. A student who will perform independently on patients, observed, and demonstration on patients or simulations. All these are right now present in the NMC book, where there's volume 1, 2, 3 has competencies, and then skill module is there. There are total 8 modules. I request everyone to go through if you have already not seen. And certification of skills is not by NMC and university. For a given skill, we can have a local teams where the BLS skills can be certified by maybe an assistant professor even. These are the certified. This is a skills lab. You can see one skill that is happening. Again, I repeat, skills lab is not a multi-crore project like Bahubali. It is a one skill, a very, very critical skill, which is very important for our communities. See the attention of the students who are learning this. skills lab is, okay. Even assessment can be done after a student is taught a skill. Provides a safe environment not only for patient, students and alike. These are the NMC guidelines for a skills laboratory that is there in the A1.7. These are all the minimum requirements each medical college is supposed to have. And components of a skills lab are these three. Those of you, and many dignitaries, they are all been PALS instructors. In a skill station, a student will learn a particular skill. There is no time limit here. A learning station typically is that after they have learned the skills, say for example, a chest endotracheal intubation or a chest thing or an intraosseous, the case scenario is typically given, and then they work as a team. That is a learning station. Evaluation station is after how much they have learned or not is the evaluation station. So the components of skill lab is these three parts, not really the costly this thing. We need, of course, costly mannequins in a different setting. So this is like planning a skill station. You define the learning objectives, derive a lesson plan like any theory class, preparatory sessions. I will show a few more slides. Skill acquisition sessions in the form of skill station, learning station, and evaluation station. And these are the 12 features. I'll show you in pictures. These are the features. And here there is robust evidence that the skills labs are going to improve patient outcomes. This is a low fidelity mannequins are you are seeing, and IAP everywhere in the country these are seen. Naturally, this is a high school where the students are learning. A low fidelity mannequin, a 6,000 mannequin is quite okay. This is for sensitizing the community. And video vastada. This is no previous one. Mere check.
Video is not.
Video time unte cheyandi leకపోతే ఏం పర్లేదు.
Not sir.
Okay, leave it. This is వదిలేసేయండి వీడియో వదిలేసేయండి. నేను తిప్పనండి.
Go ahead. No, it's not coming.
మూవ్ అయితలే.
Go down, sir.
Right. Actually, what I wanted to say was, in the low fidelity mannequin, we are teaching the CPR breathing, actually not mouth to mouth. Of course, there are bags now everywhere. A self-inflating bag is an ambulatory device. And in the video is not, there is a high fidelity mannequin for the same chest compression. The video is not playing. Here, there is the mannequin is attached to the machine where the depth of the chest compressions, the rate of the chest compressions, that is taught. So this is precisely for maybe a general medicine postgraduate and.
Eco हो रहा है sir. Eco हो रहा.
Okay. Now, sir. Now. Please share. Now is it okay, sir?
It's okay, sir.
It's okay.
All right. So now this is a skill lab where the anesthesia postgraduates, general medicine postgraduates, all they have sit down, and there is a case that goes. It can be there are 10 scenario, whatever scenario you want to give to the students, the team of students you give, and the complexity you can go depending on the performance. This is the deliberate practice. You allow the student after a demonstration is made, which is called DOAP. The students are left with the options to practice. This is called a deliberate practice. They are practicing the insertion of, now the boys are also have come here. Previously it was girls and the woman teacher. Now slowly the boys have also joined to learn this skill. More deliberate practice, a foreign body they are teaching, and here, and it's a bandage they are applying. And documentation is very important. Documentation is two types. Here, when how much time the lady has took to, the student has took to intubate, that is one documentation into the case sheet for patient care. And this is the documentation of how we maintain the skills lab. For undergraduates everywhere, in this hospital and the hospitals around, there is a undergraduate, they come and the attendance is 100% here. And we know the UG attendance for a theory class, all of us know as teachers. And once the session is completed, there is a debriefing is very important. Debriefing is not same as a feedback. Debriefing is what has actually happened, all the events from A to Z. Here, after a delivery session is planned on the right side, the instructor is giving the debriefing. Here, after a infant is resuscitated, another debriefing session is going on. That is very, very important for how much the students have learned. Then it is curriculum integration. That means now they have confidence of inserting an IUD device, and then internship or before their internship under supervision they perform the same skill on patients, real patients. So this is called curriculum integration and outcome measurement. A teacher needs to give more time than his usual time of preparation for his lecture. It is the not the mannequins, not a special room. Of course, it is the lesson plan that should happen, and infrastructure. This is for each skill that we plan. This is called a demonstration, a dope session for a urinary catheterization. Why this skill on a mannequin? We have plenty of patients. It's a simple skill. I'm finishing. But then all of us know that urinary catheterization, which is left to younger students, we know that there are many accidents that have happened, including urethral ruptures and whatnot. So this is a very important critical skill. So a skill lab session is very important. Here a student will be demonstrated, and a student will observe first, and then student will be allowed. And this is not an assessment skill. Dope is a skill where a student would learn. It's basically a learning skill. Catheterization very much needed. Delivery very much needed in a skill lab. And this is the evidence that TOPS is a superior method of teaching in a skills lab than a classical tutor system. And another evidence, reversed evidence, that skills lab are very useful. Here, a practice session by faculty members itself. Before you call your students for a session, you practice yourselves. And these are the checklists for a simple suturing. And these are the checklists of our IAB pals. Thank you very much. So a skills lab is one important component of the modern day teaching in every medical college. That's why NMC has made it mandatory. And use of a skills lab, a medical teacher need to give more time for the students. And then I remember as a student, the intraosseous that I have learned during my this period, it has come as a lifelong learner thing, and that NRC thing again. These are the two skills I would say which I have learned, which has given a lot of impact. Thank you for the opportunity. Thanks for giving opportunity to me personally and to the Niloufer Hospital. Thanks all.
Thank you. Thank you so much, sir, for elaborative on the skills lab. Sam, as you said, I know you are very passionate about SAM, even Basavaraj sir was mentioning, but we have had 2-3 faculty speaking on SAM. So I requested you to go ahead with the skills lab, which is first of its kind presentation in academics with the institution. Thank you. Thank you so much, sir. You can continue with the proceedings.
Presentation.
Yes, ma'am.
Mallikarjun.
Next, the case presentation. Regarding research, madam, almost all professors here have about their 35 publications. And right now there are 5 ICMR projects that are going on. One is on childhood tuberculosis. And Dr. Usha Rani, she was previous superintendent. On promotion, she has just gone to one new medical college as superintendent, Nagar Karnool. She has brought this hemophilia research, which is going on even now. The patients get the inhibitor factor 8. Which one?
Non-factor emicizumab.
Emicizumab, which is given quite routinely. There is a mechanism. She made this mechanism very routine, where emicizumab is procured from the government and the poor patients are given. I thought this is one point I wanted to add to my teacher, Tilak Chandrapal sir. So there's a case presentation now by Dr. Mallikarjun, which is and mentor is Professor Suchitra madam. Oh, to Mallikarjun, ready?
Good afternoon, respected dignitaries. This is Dr. Mallikarjun.
Yes, continue, Dr. Mallikarjun.
Good afternoon, respected dignitaries. This is Dr. Mallikarjun. I bring you the case presentation under the guidance of Suchitra ma'am, Professor of Pediatrics in Niloufer Hospital. Coming to the case, an 8-year-old male child was brought to the hospital with chief complaints of abdominal distension since 1 week and fever since 4 days. The child was apparently asymptomatic 1 week back when the mother noticed the child had abdominal distension, which was insidious in onset and gradually progressive, associated with abdominal discomfort. Fever was acute in onset, high grade, intermittent, with no diurnal variation. It was not associated with chills or rigors and was relieved with medication. There was history of loss of appetite since 3 days. Past history, no history of similar complaints in the past, no history of similar complaints in the family, and birth history was uneventful. Developmentally, the child has normal scholastic performance as per the age. Immunization, the child was immunized up to 1 year of age as per the National Immunization Program. Nutritional history, there's a calorie deficit of 815 kilocalories and a protein deficit of 14.7 grams. Socioeconomic, the child belongs to upper lower class as per the modified Kupuswamy classification. General examination, the child is conscious, coherent, and well oriented. There is no pallor, icterus, cyanosis, or clubbing, but a few discrete mobile non-tender lymph nodes could be palpated in the level 2, 3, 4A, and 4B of the bilateral cervical region, each measuring less than 1 centimeter. The vitals were stable except for respiratory rate, which was mildly elevated. Anthropometry, height for age is the child height for age is 50 to 90th centile, weight for age is 25 to 50th centile, and BMI for age is 50 to 10th centile. Head to examination revealed no findings except for a 4 by 4 centimeter single hyperpigmented lesion, plaque-like lesion with scaling and a well-defined border noted over the extensor aspect of the right elbow. Based on the findings, we've examined the gastrointestinal system first. The examination of oral cavity was normal. Examination of the abdomen. On inspection, the abdomen is uniformly distended. Skin over the abdomen is shiny with prominent veins seen. The umbilicus is everted. All quadrants of abdomen move symmetrically with respiration with no visible pulsations, scars, or sinuses. Flanks were full. Hernial orifices were free and external genitalia were normal. On palpation, there is local rise of temperature over the abdomen. There was no tenderness, guarding, or rigidity, and liver and spleen were not palpable. Shifting dullness was present on percussion, and fluid thrill was absent. And on auscultation, normal bowel sounds were heard. The examination of the CVS, respiratory, and CNS systems revealed no abnormal findings. Based on these findings, our initial differentials were: 1, it could be due to infections such as abdominal tuberculosis or HIV. 2, it could be malignancy such as a lymphoma. Or 3, it could be an acute phase Budd-Chiari syndrome. Coming to the investigations, the abnormal investigations I will be mentioning. ESR first hour is 12, second hour is 46. Ultrasound abdomen and pelvis showed that there were loculated ascites. CECT abdomen showed diffuse omental thickness with fat stranding and gross ascites and edematous bowel loops. MAN2 was 12 mm. We done a gastric aspirate and ascitic fluid CBNAT, which was negative. Ascitic fluid, we had a high protein, 4.92 grams per deciliter, and ascitic fluid albumin was 2.39 grams per deciliter, with serum albumin being 3.1, which gives us a SAG of 0.77, meaning that it's exudative. And adenosine deaminase levels were 42 units per liter, which was elevated than the normal. And we've done the cultures of blood and ascitic fluids, which showed no bacterial growth. And we performed a skin biopsy of the lesion, and it showed that epidermis with a squamous epithelium with hyperkeratosis and parakeratosis with follicular plugging and elongated ridges. Papillary dermis and upper dermis shows multiple granulomas composed of histiocytes, epithelioid cells, and Langhans joint cells. Perivascular and periadnexal chronic infiltrates were seen, which was all suggestive of tuberculosis verrucosa cutis. As we can see here, there's a multinucleated giant cells. It's a Langan giant cell. Based on that, our final diagnosis was it's a case of abdominal tuberculosis, peritoneal type with TB verrucosa cutis. Usually, tuberculosis of skin can be of multibacillary or paucibacillary type. If the host immunity is naive or low, we get tuberculosis chancre or scrophaloderma or official tuberculosis, acute miliary tuberculosis, and tuberculosis gamma. In case it's a paucibacillary mode where the host immunity is high, such as in a normal individual, we can get tuberculosis verrucosa cutis, lupus vulgaris, and tuberculoid reactions. These are some of the common cutaneous manifestations of tuberculosis. The most common finding that we usually see in pediatric setting is scrophaloderma. It's usually due to the contiguous spread of an underlying tuberculosis lesion to the overlying skin, and we can also have lupus vulgaris, and which usually presents over the face and sometimes over the arms, and which usually gives apically nodules on diascopy. This is an actual typical lesion of TB verrucosa cutis, which actually presents as a warty lesion. Here we have and then we have lichen scrophalozorum. Lichen scrophalozorum is actually a hypersensitive reaction to TB bacilli. And thank you for your time.
Shall we proceed with the second case, or there will be any questions?
At present, there are no questions, sir. Can take up in the end, no problem.
Present.
If Dr. Suchitra has to share something, she can.
Yeah. Yes.
I wanted to.
Yes.
Yes, sir.
Just when there is SITs, the JVP becomes very important. JVP you have to mention. Whether it is raised, it is not moving, particularly pericardial effusion, constricted pericarditis, these things. When there is malnutrition and only ascites is there without any edema, all those things, you have to think of abdominal tuberculosis. These are the 2 points I wanted to.
Yes, sir. Yes, we in this case, what we have actually found out was, ma'am, when we were doing the case, when the child was admitted with a history of abdominal distension, first 3 days of fever that was mild grade or high grade initially, then it didn't open up to say that it is an infectious cause. They did not give us a prolonged history. There was this abdominal distension was quite for a few days what the history has revealed initially. But just examining the child completely head to toe examination, then we could catch that patch which was there on the elbow. When we asked about the patch, even then the mother was not in a position to say whether it was seen from when it started or how it progressed. She just left it like a injury that had happened 1 year back. So, and a 1 year back injury will not cause so much of plaque formation. So that made us to realize whether this is something to do with the condition. So, but as we see, the skin cutaneous form of tuberculosis is different from what we see with the abdominal tuberculosis. These two are not related. The very reason for why we have to present this case is this cutaneous reaction, which is a hypersensitivity reaction. This happens to come across if the child is in constant contact or exposure. So when we have seen this and we asked them about what their surroundings are or how the child is placed, then we came to know that the neighboring area where he plays around is a place where they have the TB patient who is on and off on the drugs and not in proper usage of tuberculosis drugs. So because the child keeps playing around and going around, getting exposure to that areas has made him have the skin lesion. And coming to the hematogenous spread, which is there, the abdominal tuberculosis, this because the child's immunity was low and he was not immunized with other vaccinations on time. So this has caused the child to end up with a abdominal tuber. Even we did not get a CBNAT positive, but a CT finding which was having a classical finding of your bowel loops showing the fat stance, and then this all made us See, and also the clear ascitic fluid, which is a light yellowish in color, they did not give us any clue about it. Then the SAG ratio has given us some clue that it is an exudate. So all these are the findings that we go across. Not only just seeing a CBNAT or a lymph. And another important thing here we have seen is the cervical lymph nodes, which were not so specific, but there are significant group of number of lymph nodes. There are no matting seen. So all these points that whenever we have to see a case, we should not miss out on tuberculosis, which is a treatable cause, and this will not end up the child in further damaging his systems. That is what I wanted to convey from this case. Thank you, ma'am.
Shall we proceed for the second case?
Yes, sir. Please, sir.
Right. Dr. Dr. Priyadarshini. Dr. Srikanth, Dr. Priyadarshini, go with your case.
Good evening, everyone. I'm Dr. Priyadarshini. I'm presenting a case under the guidance of Dr. Srikanth sir, Associate Professor of Niloufer Hospital. A 7-year-old female child, resident of Amberpet, was brought by a father with chief complaints of cold since 3 days, cough since 3 days, which was non-productive. There was no postural or diurnal variation. Fever was there for 2 days, which was high-grade, intermittent, which was not associated with any chills or rigor, and difficulty in breathing since 2 days. There was no history of orthopnea or paroxysmal nocturnal dyspnea, or there was no history of bluish discoloration or chest pain. There was no history of upper respiratory tract infections. Past history, there was history of multiple admissions in the past in view of fever, cough, and cold with respiratory distress. The child was requiring multiple blood transfusion on every visit. Child was started on iron folic acid on second admission. Family history, no history of similar complaints in the family. Birth history was uneventful. Child goes to school. There is with good scholastic performance. Child is immunized till date. The nutritional history, child has a calorie deficit of 315 kilocalories and protein deficit of 5 grams. Belongs to a lower middle class family. On general examination, child is conscious, coherent, well-oriented to time, place, and person. Pallor is present. Grade 2 clubbing was present. There was no icterus, cyanosis, koilonychia, lymphadenopathy, or edema. Vitals at the time of admission was pulse rate was little high, 130 per minute, which was regular in rhythm and normal in volume and character. Respiratory rate was also high, 38 per minute, with saturations were also lower in room air, 86% with 92% with oxygen supplementation. On head-to-toe examination, no dysmorphic features were seen. Grade 2 clubbing was there. Anthropometry, the child's weight and height lies under 3rd to 10th centile. BMI lies under 10th to 15th, 25th centile. On respiratory system examination, there was subcostal and intercostal retractions, and dullness was noted on percussion in inframammary, infraaxillary, infrascapular, and interscapular areas, whereas the air entry was reduced in the above areas with Krebs were heard. On gastrointestinal examination, liver was palpable 4 centimeter below the right costal margin, which was non-tender, firm in consistency with smooth surface. Spleen was palpable, which was grade 2, smooth surface, firm in consistency. Liver span was also high, which is 14 centimeter. Cardiovascular system examination was normal. Central nervous system examination was normal. So what we initially thought was child presented with cough, cold, and increased burger breathing. So we thought there is an underlying pneumonia. Along with that, due to the need for multiple transfusion and anemia, we thought of hemolytic anemia also, mild form of hemolytic anemia without jaundice, like thalassemia intermedia. And as there was already there is organomegaly, we also thought of a storage disorder. And as there was multiple admissions in view of cough, cold, fever, we also thought of it could be inborn error of metabolism or some interstitial lung disease which is inherited. And at last we thought it could be connective tissue disorders. So to rule out infections, we did MAN2 and CBNAT, which was negative. Complete hemogram showed HbO of 6.19 with corrected retic count of 2.7. We did HP, HB electrophoresis, everything which is normal. In this child, iron levels were low with transferrin saturation levels were low, and ferritin was also low. Ferritin was also high. So there was iron deficiency anemia in this child. Along with that, LDH was also high, 817. To rule out immunodeficiency, we did serum immunoglobulin levels, which was also normal. X-ray at the time of admission showed bilateral homogeneous opacities were there, more over the paracardiac areas. So we went ahead with CT. CT shows nodular opacities, ground glass opacities in bilateral right and left lobes of the lung, and mediastinal lymphadenopathy was also seen. So it is like ground glass appearance, which was suggestive of some pulmonary hemorrhage, or the DD was pneumocystitis pneumonia. In this child, pneumocystitis pneumonia was unlikely, so we went ahead with the workup for pulmonary hemorrhage. In such cases, in children, pulmonary hemorrhage could be due to three causes. One is Goodpasture syndrome, so we did anti-GBM antibodies which were negative. Second could be due to immune complex deposition mediated mechanism, so we did vasculitis workup P-ANCA and C-ANCA, which turned out to be negative, and we did ANA, which was also negative. As there was pulmonary hemorrhage, we went ahead with bronchoscopy and did bronchoalveolar lavage. In that, RBCs were seen, which is 180, and WBCs were also seen, 450. In that, macrophages were 70%. On H&E stain, we did both H&E stain and Pearl stain. H&E stain also shows big macrophages, and the same on Pearl stain, which is stained blue. These are all macrophages, iron laden macrophages, hemosiderin laden macrophages. So our diagnosis, we put as idiopathic pulmonary hemosiderosis. It is a diagnosis of exclusion. There are only 26 cases reported as of now in India. Incidence is around one case in million case, which is diagnosed once in a year. Usually, this is a diagnosis of exclusion. There should be no other system involvement, renal involvement or cardiac involvement, and biopsy should also be normal. Some cases which are diagnosed as idiopathic pulmonary hemosiderosis will later land out to be any immune complex mediated disorders like system SLE or microscopic polyangiitis or Goodpasture syndrome also. So idiopathic pulmonary hemosiderosis usually presents as transfusion dependent microcytic anemia with pulmonary symptoms. We usually mistake it for hemolytic anemia and work up for that, but miss this diagnosis. So we have to keep in mind, when a child presents with pulmonary symptoms, anemia and jaundice, we have to keep pulmonary hemosiderosis in our mind so that we won't miss such cases. And once we find that the pulmonary hemosiderosis, early initiation of treatment with systemic corticosteroids are very important, as it increases the survival rate. There is a study conducted for this, where it shows that children on long-term corticosteroids have 86% survival rate at 5 years after 5 years, whereas not on corticosteroids usually die within 2 years of diagnosis. Thank you.
Madam. Thanks to the for giving us this opportunity to. Can I speak?
No.
Am I audible, ma'am?
Yes, sir. Continue.
Audible.
Yeah, thank you, sir. Thank you for the Central IP for giving us this opportunity to present such a rare case. Actually, whenever we see this case, it simply had running nose, cough, fever, and distress, which just looks like a simple LRTF due to viral infection. But in this case, we thought that it would be like as a child is short stature with hepatosplenomegaly. We thought it would be like any storage disorder or something else. The only contrary to presentation is even if the child had a pulmonary hemosiderosis, he should have presented with the hemoptysis, but the child never had presented with that one. But as we started working up for this case, when we have seen that mild haziness, we thought initially of either a late presentation of a cystic fibrosis or a pulmonary tuberculosis, where they came out to be negative. And when we have done CECT, they have given us the possibility of diffuse alveolar hemorrhage and pneumocystis carinii, which which is less likely possibility, but diffuse alveolar hemorrhage was one of the possibility. So how to consider now diffuse alveolar? That means we have done Pianka and Sianka and other associated, even rheumatoid arthritis or SLE can also have the presentation. We have worked up for that, which showed out to be negative. So this idiopathic pulmonary fibrosis is a very rare presentation, which we have presented to you now. So which is very less, as rightly said. Now we had in the world only 25 to 30 cases of idiopathic pulmonary hemosiderosis, which is of diagnosis by exclusion. Thank you. Any question?
Thank you. Thank you so much. Yes, sir. Vasan, sir.
Great presentation by Niloufer. And thank you, Priya, for choosing such a good academic institute for this. I think it's an inspiration for all other institutes. They are going to come up कि Priya हमारा भी cases present करो करके. Thank you, Niloufer team. Thank you.
Thank you. Thank you so much, sir, for staying till the end. I think Niloufer postgraduates are lucky to be listened by our national president. Thank you. Srinivasan, sir, any thoughts from you?
No, I'm waiting for Pramod joke. Very good cases, well worked up. Yeah, I will not waste your time, so I'll ask. I'm waiting for Pramod jokes. This thing compilation.
Yeah, we will go to Pramod Jog, sir, in the last, as we want everybody to keep waiting. JC, sir, any comments, suggestions?
Thank you very much, Priya. I think both the cases were very, very interesting and very well worked up. Just one or two small comments. I think the first case is very important to get a bacteriological diagnosis. And I think we should do a lot more of investigations in terms of looking at maybe a CT of the chest, looking if there's any chest involvement. Because since it was mentioned that this child has been in contact with somebody who's had tuberculosis in the vicinity, we don't know whether this is a primary tuberculosis or whether this is a resistant tuberculosis. So I think it's important to get to the microbiological diagnosis. So that is my comment on the first case, because sometimes repeated testing is what will get you a bacteriological diagnosis. And the second case, which was again a very good case and an excellent case, there are many causes of pulmonary hemorrhage. And here the giveaway was the very characteristic feature of an elevated ferritin with a low iron and a low iron deficiency anemia. So there is some inflammatory process going on. So I think it's important for us again here in the second case to look for an environmental issue also, because sometimes we have seen external fungal agents also producing pulmonary hemorrhage recurrently. So I think the diagnosis of idiopathic pulmonary hemosiderosis is one of exclusion. And the other point which is very important to mention is that the stain that she showed there showed a large number of hemosiderin-laden macrophages, because there is a cutoff. If you have a few number, it is not significant. And I think the numbers also should be mentioned as to what was the percentage of hemosiderin-laden macrophages found in the staining at the site. Otherwise, both the cases were very good and excellent and very well worked up. Congratulations to the Niloufer team.
So can they present with such a short history of 3 days cold cough?
Yeah, I think the point. I think the point was the thing.
Yeah.
I think the point, Priya, is not that this was 3 to 4 days. remember that this child is chronically sick. There is something going on for a long time. There's a repeated blood transfusion. So the child is losing blood somewhere. This is not a hemolytic anemia nor an aplastic anemia. So there's a blood loss anemia happening somewhere. And this is obviously not something which is bleeding externally anywhere. So there is some bleeding taking place inside. So I think the important thing here to realize is that this is a chronic disease with an acute manifestation. That is acceptable.
Even sir, as we have worked up, it's that may be the precipitating factor. Every time it used to present with that one and had a repeated blood transfusions. We never considered the diagnosis of idiopathic pulmonary fibrosis in our primary initial thoughts. But as it's a even we have not thought diffuse pulmonary alveolar hemorrhage. Only after once we have done CCT, then that has given us some clue where we need to work up for something else. Thank you.
Excellent.
Sir,
Ramakrishna
in
sir?
the
Yes.
first case, what I have to tell you, madam, the CT chest was normal. Biopsy for the abdomen, when we have seen the fat laden, the intestine loops. So we wanted to do from there, but because there was constraint about this to get a TB. Also, twice we have sent the fluid of ascites for the CB-NAT. We never got a positive. Also, we have sent for culture so that it may grow at some point of time. We are waiting for the culture because
What is ADA?
Madam, ADA is 42, which
so
is
that
not.
is enough. You have a good ADA,
Yes,
which is
yes, ma'am.
42.
That made, yes,
And
ma'am.
what was your SAG and protein albumin?
SAG was 0.77, madam. That made us an accident. Yes.
Okay. And with the serum albumin of?
Albumin was 3.1.
Serum.
Yes, madam.
And the ascitic?
Ascitic albumin was 3.1. The serum albumin was 4.7, 4.1 or 7, 4.9.
कितना difference आ रहा है?
Yeah, ma'am.
Yes,
It is
ma'am.
coming around 1.
So
Difference
because
between the two.
that's what you don't need to do. First of all, you need to realize that CB-NAT and the PCRs, the yield is going to be very less in the peritoneal one. What he presented was peritoneal.
Yes.
Peritoneal is a very special type of tuberculosis where you may not find the other, it may not be your chest and other organs, and then you get confused. So though the gold standard is doing a laparoscopy biopsy, but theoretically, we do not always say that. If you have a good supportive cytology, which is, suggestive of lymphocytic predominance and exudate, which is high protein and low SAG, and ADA, which is positive, you are justified in starting the ATT.
Yes, ma'am. We started only based on that. It didn't take so short time how we presented here, but it took us around 10 days time because the presentation history was very short. A duration of 3 days of fever and presentation like this, child was acutely sick when he was presented. So this made us to come to the diagnosis that we can start ATT without even having a proper CB-NAT or other finding. Thank you, ma'am.
And how's the child doing now?
The 1 month the child came back, ma'am, and we have started after starting ATT. This cutaneous lesion which was there on the elbow has disappeared. It was normal. The varicosa cutis, that is another important thing we wanted to say. Like 4 weeks or 6 weeks after the treatment, it has come down, and even the abdominal ascites also has started regressing now. It is a minimal fluid with which he has come back, and child is improved on his nutritional status as well.
And liver enzymes were what?
Liver enzymes were normal, madam.
Check again. OT and PT, exact what it was. No, I mean initial. They should be just borderline increased, usually.
They're borderline. Yes, they're borderline. Actually, they have been borderline only, madam. What we have started.
They can't be normal because it's not disseminated, but due to inflammation, you get that effect.
Yes, ma'am.
Okay, dear.
Thank you, ma'am.
Thank you so much, ma'am, for those inputs. Ramakrishna sir, you have had many questions and suggestions. Over to you, sir. Yes, sir.
Adi sir, అందుకనే present చేసింది.
Good evening, all. It's a very good presentation by the residents. But what I feel, it's not exactly comment as an elderly, some suggestion. And actually, the analysis of the symptoms, signs, and correlation would have been more useful for the residents than, sorry to say, relying on the investigations, especially in the first case. Yes, microbiological confirmation is essential, but there are certain cases like this tuberculosis ascites. It is not essential that CB net has to be positive. The clinical picture is very much supportive, and the resident would have mentioned about the dovey feel of the abdomen. Seniors like Dr. Tilak will be knowing, and dovey feel is classical of tuberculosis abdomen. Once we feel,
This
it's
is
difficult to
ascitic
forget
type of
even. So,
abdominal
with the
tuberculosis.
clinical picture, there cannot be any other diagnosis but for tuberculosis abdomen, peritonitis, and one can palpate for rolled up momentum also. Those two things should have given the clue with support of dermatological lesion. Yes, it can
This is ascitic
be
type, sir.
diagnosed as tuberculosis. Regarding the second case also, the resident would have been more explicit by excluding the other diagnosis by way of symptoms and signs rather than with the help of investigations. We are students, right, sir? Dr. Vijay Kumar, at least I am student. That's why I would like the analysis of symptoms and signs and correlation and exclusion of other conditions. Then only we can say it is pulmonary hemorrhage, right, sir? Thank you. Thanks for the opportunity.
This is a ascitic type of tuberculosis with adhesion. So that's why there is no
Thank you,
fluid
sir.
field
That's all.
also they couldn't get.
That's what I want to tell.
Yeah.
Thank you for that remark, sir. Lastly, we are coming back to Pramod Jog, sir. We are waiting. We missed you for the
Thank you,
last
Paleda.
1 or 2 episodes. Request for your summary, sir.
Actually,
Jogisms, yeah.
yeah, thank you. Actually, this program was as crispy as the Karachi biscuits of Hyderabad and as tasty as the Hyderabadi biryani, I must say that. And it was a pleasure to have Dr. Jagdish as a pulmonologist and Dr. Neelam as the gastroenterologist for the 2 cases, because both the cases were related to these specialties. And then I must say, this was another pearl in the feather of Niloufer Hospital. Hyderabad is famous for pearls. And I was just speaking to my wife in the morning about how to test a real pearl. Okay, so she said that usually they use some burning test. Okay, and once the burning test is used, and if the pearl stands the test, then it's a true Hyderabadi pearl. Of course, I will have to come to Hyderabad to know whether it is true, and Vijay Kumar can guide me on that. Doesn't matter. Of course, this Niloufer, and we all saw how beautiful she was. And for a moment, I kept looking at the photograph only. But and of course, Dr. Suresh Kumar told everything about the institute, how it got established in 1953 and has almost more than 1,200 beds, and it has 200% occupancy. Okay. Some of our medical colleges are fighting to get even 10 patients, but here, it is full with more than 2,500 patients. And it has so many firsts to its credit, like the Institute of Child Health, the neonatal unit, that I remember he told about that pediatric surgery, and so many. And what impressed me most was that virtual rounds, which are really helping our peripheral people. We could see our experts who are guiding the peripheral rural colleagues, because for those patients, it's very difficult to come to major centers or the metropolis. So it's a very good, what you say, gesture of this ESNCU doctors. And whenever we think of Niloufer, we cannot forget all the dignitaries connected with this hospital. Dr. Harish Chandra, Dr. Y.C. Mathur, Dr. A.S. Narayana, Dr. Lavanya Mukherjee, Dr. Y.R. Reddy, Dr. G. Purushottam Rao, Dr. Subramanya GVS, I think he is in the our viewers today, Dr. P.S. Murthy, who was with me in the executive board long back, Dr. Sheila Karan, Dr. B.C. Mathur, Dr. Indra Shekhar Rao, and Dr. P. Sudarshan Reddy, and Dr. Ranganath Daruru, our ID chapter president. So all of these people have been associated with this Niloufer Hospital. And whenever I went to this institute,
Dr. Hema Binda also.
Oh, yeah. Of course, I think now she is at some other hospital, but she has been associated and with this hospital for so many years. And the chain of pedicons which has been witnessed by this hospital. 1963 was the first pedicon, and then there were many after that. and visited by so many dignitaries like Nelson and Dr. Dharampuri Vidyasagar and so on. So it's a great institute with tremendous history. And for a change, Dr. Vijay Kumar, told about the skills lab. And I was really very happy that he brought out this point, because our postgraduate students many times they are afraid of doing lumbar puncture, venipuncture, and neonatal resuscitation. So this is one place where they can do a low risk learning. The seniors are after them. Don't do LP, which is traumatic. Don't do LP, which is traumatic. So this poor first year resident is always under a lot of pressure. So it's a low risk learning and error friendly setting. He can commit errors, and the learners can make and correct the mistakes, and it will promote the deeper understanding. And it's not only the mannequins. There are people who feel that skills lab with those mannequins. It's not so. And Dr. Vijay Kumar made it quite clear that this particular skills lab is something which is going to be the mainstay of education in the undergraduate curriculum. So I feel it is an indispensable part of pediatric medical education, which enhances the clinical competence. There are many who are afraid of intubating. There are many who don't know how to nebulize a child. And it's not only about it, but also care discussions and building up confidence and improving communication also. So I must congratulate Dr. Vijay Kumar for showing all those important points related to this important component of the modern day teaching, and also the skills like intraosseous IV therapy. There are many things which we can take from your presentation, and I am very happy that you presented this. You also told about the research related to hemophilia in this particular institute. And then the two pearls, one Dr. Mallikarjun, under the guidance of Dr. Suchitra, presented that case of 8-year-old chap, boy with that abdominal distension for a week and fever for 4 days, and a hyperpigmented lesion on the elbow. And it was, thought by them that it could be abdominal TB, HIV, or a lymphoma, or Budd-Chiari syndrome. But they found that there is exudative ascites. And the most important thing that they found was the skin lesion after biopsy was that tuberculosis verrucosa cutis. The important point that we must remember is that tuberculosis of the skin can present in different ways. But scrophulоderma, for example, it occurs from underlying tuberculous focus. But what Dr. Suchitra made clear, that tuberculosis verrucosa cutis is because of the direct exposure to the tubercle bacilli. It is not a secondary form of tuberculosis. So that we must remember, and that is after direct inoculation of the bacteria into the skin. That is something we must remember. And that's why this abdominal TB, which is connected with this hematogenous spread, no doubt was there. But tuberculosis verrucosa cutis, the spread was not from that abdominal TB. Of course, the treatment, of course, remains as the anti-tubercular therapy. And Priyadarshini, under the guidance of Dr. Shrikant, she presented that child, 7-year child with acute history of cold, cough, fever, and increased work of breathing, who was found to have short stature and hepatosplenomegaly. And they thought of this hemolytic anemia in view of the multiple transfusions. Of course, they thought of storage disorders, inborn errors, and interstitial lung disease and connective tissue disorders. And it turned out to be a case of idiopathic pulmonary hemosiderosis, where there is accumulation of iron in the lungs. And of course, many times the diagnosis is histopathological with, as Jagdish said, intraalveolar hemorrhages and the hemosiderin-laden macrophages with interstitial fibrosis. I understand it was a rare case, but it was good that we can remember that a short duration history of respiratory symptoms can, if worked out well, we can come to some diagnosis where, in case if you have a transfusion dependent anemia of microcytic nature, along with some concomitant pulmonary symptoms, we can diagnose such conditions which are rare, and we can treat them early with steroids. So I must say this was a great program, different, than many other programs earlier. And it had a design like the Kalamkari design of Hyderabad. I know Kalamkari design is very famous, and you can use it either for the cotton or the silk saris. and I have spent a lot of time in the Banjara Hill area finding, all these sarees. But I could always, get the one in some of the remotest corners of Hyderabad. Okay, so Dr. Vijay Kumar and your colleagues, congratulations. And whenever I come over there, I will have some nice Usmania biscuits, which I know are available just outside Niloufer, along with the Irani tea, which is so very famous outside Niloufer, and so many
Come
other
tomorrow, sir.
things.
Come tomorrow,
Yeah.
sir.
Oh, somebody wants to add some food item, I don't know. Anyway, and then along with that, the famous dish of, halim along with mirchi ka salad. There are so many tasty things in Hyderabad, but I can come over there and we will enjoy together. Thank you. Thank you for a great presentation. Thank you.
Thank you. Thank you so much, sir, for that mouth-watering delicacies of Hyderabad and the views, which are, I think, all will go for shopping in Hyderabad once again after the pedicon. Thank you. Thank you so much for your crisp summarization. Before I hand over to Dr. Lakshman, sir, I need to remind all of you to join for the next month session. That's on August 22nd. Will be presented from Gangtok Medical College. We are going to East Zone from Central Zone. So request all of you to join on 22nd of August. Dr. Lakshman, sir, request you to deliver the vote of thanks.
Thank you, Dr. Priya. So on behalf of Central IIT, Niloufer Hospital and Dr. Vijay Kumar team and budding pediatrician Mallikarjun and Dr. Priyadarshini, thank you one and all who have participated in this 7th episode of Academics with Institution program. Thank you, sir. Thank you.
Thank you so much, sir. I would like to take the name of Chief Guest, sir, respected Dr. C. Suresh Kumar, sir. Thank you so much for gracing the occasion and staying till the end of the program. Dr. Vijay Kumar, sir, thank you so much for coordinating so well with me, though it was a very short time. I know we cancelled 3 times last year. It was possible only because of Guru Prasad, sir, and yourself accepting to do the program this year. Thank you once again. Tilak Chandrapal sir, thank you so much for being here. And Dr. Suchitra, Dr. Shrikant, thank you so much for your contribution. Congratulations to the postgraduates, Dr. Priyadarshini and Dr. Mallikarjun, for wonderful presentations. Thank you. Thank you
I
all.
just wanted to make a comment, not that I'm from there, but really you are a class apart because the presentation, sometimes they do so long, but we are all pediatricians. This is not a postgraduate class. Though you're expecting postgraduate because we take specifically for the postgraduates. It's like a curve. So what you all presented with just perfect, crisp to the shot with the messages rather than making us sleep. Amazing it was. Thoroughly enjoyed. Keep up the good work.
Yes, ma'am. This is our template. Some of them don't follow.
Very
but I think
nice.
Vijay Kumar sir very neatly followed the template. Thank you. Thank you, that. Thanks, ma'am, for staying till the end and contributing. And Pramod Jog, sir, thank you so much
Thank you.
for coming
Thank you very
back
much.
to our session. JC sir,
Good night, all
thanks
of
for
you.
your guidance. Srinivasan sir, thank you.